webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. Welcome. Thank you for joining us. Before I introduce tonight's presenter, I'd like to call your attention to the slide on your screen with the details of our April 6th New Jersey Walks for TS event in Princeton. The proceeds from this walk will support our scholarship program for graduating New Jersey seniors going on to either 2- or 4-year college programs. We hope that you'll join us that day, and if you can't, please consider making a donation in support of our scholarship program. Now to the introduction of tonight's presenter, Dr. Rachel Strohl. Dr. Strohl received her undergraduate degree in psychology from George Washington University in Washington, D.C., and her master's and doctorate degrees in clinical psychology at Rutgers University Graduate School of Applied and Professional Psychology. She is a licensed New Jersey psychologist with an extensive background treating children and adolescents, college students, families, and adults living with a broad range of anxiety and OCD issues. Currently, Dr. Strohl is a clinical psychologist at Stress and Anxiety Services, a group private practice in New Brunswick, New Jersey. She specializes in the cognitive behavioral treatment of anxiety disorders with children, adolescents, and adults. She is also on the board of directors at the OCD Foundation of New Jersey. Dr. Strohl, welcome. We're delighted to have you join our webinar family. And now, without further introduction, I'll turn tonight's presentation over to you.
Thank you so much. First, I want to take the time to thank everyone who's taken their time to attend the presentation tonight. And we'll start by recognizing that our audience is quite diverse. We have a wide array of individuals. A large percentage of the attendees tonight are parents or relatives of individuals with anxiety or Tourette's or related problems. We also have those individuals, the teens and young adults themselves. In addition, we have some school professionals and those in the educational field. And what I'd like to let those individuals in particular know is that we're going to get some really great slides at the end of the presentation that really gear towards the school environment. So hang in there, and I'm sure the presentation will be interesting, but the school information specifically will come towards the end. We also have some medical professionals and clinicians who are listening tonight. So I'll definitely gear the audience towards all those listeners and hopefully make this an interesting and enjoyable evening for you. So let's get started. Tonight we're going to be talking about how to chill out, helping teens and young adults with TRIC and BFRBs learn to manage their stress and worries. So let me break down a little bit of the alphabet soup you see on your screen. So TRIC stands for trichotillomania, and what we associate with that is hair pulling. BFRBs, body-focused repetitive behaviors. Those tend to be more of picking behaviors. Let me give you some examples. It could be skin picking, which is now known in our latest DSM diagnosis as excoriation, but for tonight's presentation we're going to refer to it as skin picking, so it's easily recognized. Other BFRBs include nail biting, they include tongue biting, and different picking behaviors that occur on the body, and we'll discuss that. Even biting the inside of your palate, the inside of your cheek. There's lots of different BFRBs. And one thing that's really key to the presentation is that we can use TRIC and BFRBs interchangeably. So while TRIC involves pulling and BFRBs often involve picking or biting, we'll be using those words interchangeably. So if I'm referring to pulling, please know if you're attending as someone who involves BFRBs, I'm talking to you as well. So hopefully that feels inclusive to you. All right, some goals for today's presentation. We're going to learn about stress and worries and how it can increase hair pulling, BFRBs, and tics. And again, our audience, tonight is being housed by Tourette syndrome and associated disorders. So again, many people not only have anxiety, hair pulling, BFRBs, and associated tics. And so we recognize tics as motor or vocal tics. And again, there could be ranging from those individuals with Tourette syndrome, which involves both combinations of motor and vocal tics, to those who may have transient tics, who present one at a time and in a different manner. We're also going to learn to differentiate between common worries for teens and young adults and help you differentiate when those cross into anxiety disorders. We're going to learn about stress management tools such as relaxation-paced breathing, sensory grounding, cognitive therapy, and exposure tasks. And the goal here is to decrease the symptoms of stress and worry that we all experience to different degrees. And finally, learn to master the situations that cause stress and anxiety in our lives. So here we go. First, what causes anxiety? Well, here I have several bullets. Let's start first with ineffective problem solving. Often people report that they have anxiety or worries because they have a problem and they don't know how to handle it. And this is very common and again affects everyone. And so often what we'll do is give a skill-based approach to how to solve those problems, which we'll be talking about as the night goes on. Second, distorted thinking. This is referred to in our community as cognitive distortions. Cognitions are our thoughts, and distorted means exaggerations. So when we have exaggerations in our thinking, we're thinking in extremes, and we often find this is not helpful, and what happens when we think in extremes? It leads to anxiety. We also have difficulty accepting things we cannot change. Sometimes in life, there's things that are as they are, and instead of saying we have to fix this, sometimes we have to learn how to accept that. And by learning to accept things, not only does it reduce anxiety, but it helps us sometimes lead to change as well. And so that might sound paradoxical that we cannot change it, but by accepting it, sometimes it leads to change. And then finally, lack of coping skills. Again, when a problem is presented in our lives, how do we handle it? Do we turn to some negative coping, or do we turn to more positive coping that actually helps build us up and makes us feel like I could handle this, which in turn reduces the anxiety. Let's talk specifically about our age group we're focusing on tonight, which is adolescents, teenagers, and young adults. So there's different stresses that are naturally and developmentally associated with this age group. Number one, academic pressures. This age group's in high school, they're considering going off to college, some are in college, some are in the workforce. And so with that comes different pressures, pressures to get good grades, pressures to get the right job, pressures all over, and that could be quite significant. As I mentioned, adolescents and young adults are planning for future directions. They're trying to figure out who they are and what they want to do, and that can be quite stressful. And so as a parent listening, you can relate to that. We were all teens and young adults at one point, and we remember that uncertainty that is natural and expected at this age group. Also, it's very normal and expected that teens will look for increasing independence, and young adults as well. But with that increased independence comes increased responsibility. And that can be, as we say, a double-edged sword, because the teens and young adults really want it. You want to fly out of the nest, but that can be scary, and that brings, again, a lot of worry and stress with it. Also, social demands. A key characteristic of this developmental age group is pressure from peers. There's a natural desire to fit in. You want to be part of the group, and that puts stress on, quote-unquote, fitting in. Also, relationships are developing at this point, and whether they're intimate relationships, friendship relationships, there's a lot of potential conflict in that area and a lot of desires, a lot of uncertainty again, and so we could all understand how that leads to different stress. Developing one's identity, as I mentioned earlier, who am I and what do I want to be, whether this is someone's morals or ethics or their career path. And finally, financial stress. Thinking about going to college. College is expensive. Thinking about, as young adults who want to live on their own, figuring out how to pay their rent and different things. Even when you're in high school, you're on your own a lot. If you want to go to the movies, you have to, maybe you're having some side jobs, maybe you work, maybe you babysit, and taking that money and managing it can be quite stressful. So as you see, a lot of the different points we talked about right now can relate to many different age groups, but especially adolescents and young adults. So now let's take this normal stresses that we expect during this age group and apply it to the consequences when our teens or young adults have trich or BFRBs. And so what we see now is social isolation. The individuals and clients I work with often come in and they feel such terrible shame that they have bald spots on their head, that they're biting their nails to where it's bleeding and it's so low that they can't use their hands to write because it hurts so much, or people in school are looking at them and wondering why their hair is missing, why their eyebrows are having holes and gaps in between it, why their skin looks quite red in some spots and looks very, sometimes freshly picked, and they can't hide that. Associated with that, there's an increase of low self-esteem and a decrease in self-acceptance, and a natural consequence is withdrawing from the peers' activities, not wanting to be around because there's such shame associated with these behaviors that I should mention are all neurobiological. The hair pulling, the picking, the BFRBs, they're all different neurobiological disorders. So as we'll see tonight, there's a genetic cause to some of these disorders, but there's certainly an environmental impact that comes in and triggers and makes the problem worse at some points. Also, there's conflict in the family. Sometimes the individuals have tension or arguing with their parents, with their siblings. They don't understand why they're doing these behaviors. Why can't they just stop? I have a slide we'll get to that says that in a minute. And finally, they avoid family members. You might find as a parent that your child now, your teenager, is shutting the door. They don't want to open the door or be around family because they're fearing the judgment or consequences associated with a recent bout of picking or pulling. And finally, academic decline, distracting and time-consuming behaviors take away from school. And further, if there's a lot of visible symptoms, which these disorders tend to have, including tics in this field, which is, again, tends to be very visible, whether motor or vocal, can sometimes lead to school avoidance because the teen or young adult just doesn't want to deal with it at this point. So as I said earlier, just get over it. People, whether it's the family members, whether it's relatives, whether it's the school members who are really, really trying to help, but just as sufferers of anxiety here, why can't they just get over it? They suggest things like, just stop it or think of something else. And truthfully, if it was that easy, people would just stop and I'd be out of a job. So I really wish I could be out of a job if it was that easy, but unfortunately it's not, and it's much more complicated. The good news is there's great interventions to get control of your picking, pulling, and anxiety related to that or separate, and that's what we'll be focusing on tonight. So let's now shift gears a bit, and what we're going to go into empirically supported, which means evidence-based treatments for anxiety disorders. So now a question that I received from someone attending our webinar tonight is the differentiation between is trich and BFRBs an anxiety disorder. And it's interesting because I'll give you a little quick historic information. In our DSM-4 TR, which is our latest edition, previous to the newest publication, they put anxiety disorders in one category, and I'll go through some different anxiety disorders tonight, and then they would put trichotillomania and BFRBs in impulse-controlled disorders, where Tourette's was in disorders of childhood. So they kind of split that all across the board. Now in DSM-5, they've actually moved trich and skin picking over to, they call it obsessive-compulsive disorders and related. So while we really think of that OCD and trich or BFRBs differently, now in the new DSM, and that's just our diagnostic criteria book that we use in our field, they're combining it. So you'll hear my thinking as we go on about that and where it fits in. So now specifically talking about anxiety disorders. What are anxiety disorders? We'll get to that. There's different ways to treat anxiety disorders, and there's the 4 bullets. We have psychoeducation, learning about it, relaxation, calming the body, cognitive restructuring, detective thinking for teens is what we often refer to it as, which is basically thinking differently about an event, and finally exposure, facing our fears. So these are the evidence-based treatments that work. I'm a cognitive behavioral therapist, and I rely on the evidence. I rely on what works, and anecdotally I'll share with you some stories tonight of the treatment working, but evidence-based, and the researchers show that that is the utmost important treatment, CBT, cognitive behavioral therapy for anxiety disorders. So first, psychoeducation. You're looking at it, or I like to say tonight, you're listening to it. So first we want to explain the causes of anxiety and how treatment works. I like to explain that anxiety is a really important feeling that we all have. It's part of our fight or flight reaction back to the caveman. It's an adaptive function that we need. I like to give the metaphor that if you're standing in the middle of the street and a car is approaching, you want to get out of the way. So we need our anxiety. That's where it's going to be really helpful to get out of the way. However, what happens is our anxiety sometimes gets bigger than that. We have a student sitting in math class who feels like he's being chased by a lion. It's his fight or flight response, and his body is actually trying to be helpful and adaptive, but yet it's a misfiring, it's a miscue, like a false alarm. He's sitting in math and he's not in danger, but for some reason his body is telling him he is. And then finally, we want to learn to use the tools that help us better understand and cope with anxiety. And so we'll explain and help empower the person with anxiety to realize they are more in control than they think. As I talked about, we're going to differentiate between normal anxiety, which we all need, and anxiety disorders. And the key mark of that with anxiety disorders is when it starts to create significant distress. A person is crying and feeling very upset, and it's impairing functioning. They can't go to school, they can't go to work, they can't do the things that they used to do. And so again, where we all experience normal, healthy anxiety and worry, when it becomes an anxiety disorder is when it starts creating impairment in our lives and creating great distress. So some different types of anxiety disorders. We have different types of anxiety. The first one we'll talk about, to give you just an overview of different types of anxiety, is social anxiety. Social anxiety disorder is when a person has excessive or persistent fear that others are evaluating them. And of course, the fear is they're evaluating them negatively. So the person's worried that they'll do something embarrassing, they'll look bad, they'll be the center of unwanted attention. And so what does the person do? They'll actively avoid social situations where evaluation occurs. The problem is that this reinforces the anxiety and the quote-unquote danger that they have something to worry about, and doesn't sort of let them recorrect the fear in their mind, which is, again, overblown. Second generalized anxiety disorder, often you might have heard this as GAD, and this is characterized by excessive, uncontrollable, and often irrational worry about everyday life. That again is disproportionate. So we all worry about, we call them the minor matters. These are money issues, work problems, family, friends, things like that. We all worry about that. But the difference in GAD is a person is catastrophizing a disaster that is coming with these matters, where it's beyond the scope of normal worry. And often with GAD, a person exhibits a lot of physical symptoms of anxiety, which is quite normal with that, such as headaches, nausea, numbness, muscle tension, difficulty breathing, irritability, sweating, hot flashes. And so the physical symptoms of anxiety will occur in all the different anxiety disorders, but a person with GAD may be more aware of their physical symptoms, and that's often what they report first. And then OCD, obsessive compulsive disorder. How do we define OCD? First with obsessions. These are unwanted thoughts, images, or impulses, and they're often characterized as bizarre. They're strange, they're distressing thoughts or images that cause anxiety and distress. The person attempts to ignore, suppress, or neutralize them, and they're not simply the excessive worries that we just talked about in GAD. And the person recognizes they're a product of their mind, even though they're bizarre and intrusive. They know they're not, an auditory, let's say, hallucination, which would be more in the psychosis realm. And then finally, compulsions. These are repetitive behaviors or mental acts. And the function with compulsions is, while obsessions increase anxiety, compulsions aim to reduce or reduce the anxiety. And the main feature here is neutralizing. So again, while obsessions increase anxiety, compulsions or rituals decrease anxiety. However, our loop problem with OCD is that while it works short-term, long-term, again, we're reinforcing the OCD and making it stronger. Here we have a list of different OCD obsessions and compulsions, and I'll run through a few and give you some examples. The one that people recognize the most, although it's not necessarily the most common, but it's the one perhaps society portrays the most, is an obsession about contamination, whether it's a fear of germs, whether it's a fear of getting sick, whether it's a fear of dying. And the person might wash or clean, and so of course this is excessive. So while we're all worried if we come into contact with someone who has a cold and sneezes on us, let's say, we'll go wash our hands, this person will wash for upwards of hours. They might be in the shower for hours. They might, again, do these different rituals that are quite extensive and are taking over their life. Also, there's a concern about harm, and they're afraid either they'll cause harm, they're afraid that someone else will cause harm to them, and they do a lot of different checking or reassurance behaviors, such as they're home and they're afraid that they didn't lock the door, and of course if they didn't lock the door, a robber could come in and hurt their family. So what does the person do? They go downstairs and check the locks. But checking the lock once isn't enough. They walk away and immediately doubt if they did it, and they have to go back again and again and again to keep checking the lock, and this behavior could go on for hours. Similar, they worry that, did I shut the stove? Did I shut down other important things? Because they're worried that if they didn't, the house will burst into flames, and they'll constantly be checking. Other different examples, especially with teenagers and young adults, is reassurance seeking. And so they might go to their parents or their teachers and say, let me get this straight. So you said I have to do this and this, and they'll ask over and over. And sometimes it's a concern about harm, and reassurance could happen as a compulsion with many different types of obsessions. And so maybe it's a fear of embarrassment, which is further down on the list. They don't want to be embarrassed in their oral report they have to give tomorrow, so they'll seek reassurance over and over again to make sure they have it down just right. Again, beyond the point where, normally a student wants just some clarification with the work. Another one, need for symmetry. So I have a client who comes in my office before the therapy started, and again, we learned to manage it, not cure it, but when her symptoms were really strong, she would sit there and she would have to get up every few minutes to touch the right side of my wall and then the left side, because she felt like if she didn't touch both symmetrically, things would just feel wrong. So for her, she wasn't afraid of something bad happening, a fear or a dangerous thing happening. She was just afraid that it wouldn't feel right. And that's often the two types of fears we see with OCD. Either something dangerous or something bad will happen, or the person has that, they don't have that just right feeling they're seeking. And then they'll tend to, as you see further down on the compulsion list, do some repeating behaviors over and over because they want that just right feeling. And with mental compulsions, with OCD, sometimes a person might have a fear of contamination. They touch something that appears dirty to them, but they're not going to wash their hands. Here, they've come up with mental compulsions, something that people won't see, but they're doing constantly in their mind, whether it's counting, whether it's special words or images to neutralize that germ, let's say they just came into contact with. Also special prayers. And so it's beyond the point where it's pleasurable or it's praying for spirituality. It's praying to make the bad feeling go away and to reassure them. Let's talk a little about the link now between OCD, an anxiety disorder, and TRIC, BFRBs. And so some believe that TRIC and BFRBs are on the OCD spectrum. And so again, that there's support of that in the new DSM-5, which we talked about earlier. But conceptually, we find that there's still many differences. I like to refer to those as cousins. So often we see if people have OCD, there's comorbid disorders. And what that means, and not just OCD, but any of these presenting problems, that means they have multiple presenting problems. So a person who has Tourette's might also have OCD, and they might also have TRIC and BFRBs. And why is that? It's not directly related, but they're cousins. They're very similar on that spectrum. So we often do, it's very common to see people with multiple presenting problems. And so what we hear, though, from those people is that many people who pull find the experience pleasant. And again, remember I said earlier, if it says pull, you could sub it in with pick or, any of those kind of bite, any of those different behaviors. So they find that experience pleasant. There's actually a releasing property that happens that's pleasant. However, in OCD, the compulsions are not pleasant. They're really unpleasant, the individuals will report, and it's rather a way to reduce harm or anxiety. So that's a key difference, is people will come in with TRIC or BFRBs, and while there's great shame associated with it, they also recognize it's an enjoyable behavior, and that's why they're doing it, as opposed to the rituals of OCD, which are often not pleasant or enjoyable in any way, and they're just doing it to make the bad feeling or the anxiety go away. Now let me go into some more detail about the treatment model for trichotillomania and other BFRBs. And so we found that the comprehensive model for behavior treatment of TRIC is named the Cone-B model, and there's been some new research in the field of trick and BFRBs, the research is in its infancy. And so where we know so much more about OCD and anxiety disorders, we're really starting to learn more about trick and BFRBs. But the good news is there's a lot of great organizations like www.trick.org, and that's the Trichotillomania Learning Center. I'll repeat that later if anyone has any questions, and we'll have a slide at the end of different websites. But that's a wonderful organization that's doing a lot of research to get more information that's science-based, which is great. And here the Combe-B model has 5 categories. So there's a sensory category, a cognitive category, affective or emotions, motor, and place environment. And a nice acronym is SCAMP. So you could see that. It's a quick way to remember. And often, as you'll see in my next slide, which I'll go to now, that first we need to do an assessment of why you're picking or pulling or biting. And once we have that assessment of why you're doing that, then we can understand how to treat it. And so a nice model that's come up, another acronym here, is Fiddling Sheep. And this is a book by Gollum and Vavracek. And if you're a teenager listening tonight, I really recommend this workbook. It's a really great hands-on workbook. It's the hair pulling habit in you. And what they've come up with is a nice way to, again, assess why you're pulling. And we have here fiddling, pulling or picking again because you want to keep your hands busy. Sensation, pulling hair because it's stimulating the scalp or the skin. Habit, pulling hair, picking automatically without even thinking about it. Environment, pulling hair in certain rooms or places, trigger pulling. Emotions, pulling hair that seems to relieve tension created by emotions for that moment. And we'll talk about later that the emotions are not always negative. People don't pick or pull just for negative emotions. Sometimes they pick or pull when they're happy, when they're feeling stressed, when they're having all different types of emotions. So it could be positive and negative emotions. And perfectionistic. Hair pulling or picking increases from frustration or disappointment that the hair or the skin is not perfect, which actually in turn leads to more picking or pulling. And so we get to understand that. You'll recognize that these are triggers. And so in the Tourette's community, also it's very important to know your triggers because awareness is key if in that area you want to do habit reversal. And so a lot of understanding your triggers will be very helpful for Tourette syndrome and tics-related disorders as well. So this really does overlap, and it's a nice guide. So now let's skip into, this is the intervention, but I'm going to go to the next slide, which breaks down and gives you some very concrete strategies, which I know everyone likes to hear in a presentation because it gives you that concrete, what do I do? So for those listening, if you're pulling right now and saying, how do I stop? I know I'm a fiddler. I pick and pull because I want to keep my hands busy. Here's some strategies. And as you see, the list is extensive, but you can add to this numerously. I have clients who are so creative who come in all the time and said, I came up with this idea or that idea, and this works for me. I had a client the other day who was wearing this really cool necklace that was feathers and beads, and she said, this helps me in high school because I get to wear this cool necklace and I get to play with it and no one knows what I'm doing. And that's always something we're sensitive to. We want to make all the different interventions, you know, some are better for home and some are great for school or in the public environment because we want to maintain your privacy when you're doing these kind of strategies. So as you read down the list, a koosh ball. I give all my clients mini koosh balls that they stick in like their pockets at school and they're playing with them, keeping their hands busy, and no one thinks twice about it or thinks that some of the teenagers really like those cool pencils that have the hair on top of it. So they get to hold a pencil, which is totally normal for school, and they get to keep a fiddle strategy in their hand. Other different ones that are really helpful are silly putty, polishing their nails. If you're a nail biter and that's your BFRB, then you want to have some kind of deterrent to block that. If you're also putting, sometimes people who pull their hair chew on their hair, or they're putting different things in their mouth, and so we'll put different things in your mouth as an intervention, chewing gum, sucking on candy, that'll block it. Also, eating sunflower seeds is great because not only do you have the fiddle of getting those things open, but then you have the activity of keeping your mouth busy as well. And you'll see some from the list, again, different things to keep your hands busy. Next, sensation. Instead of pulling or picking, give your body the attention it needs. So as I talked about earlier, sometimes pulling or picking feels good. And so what do we want to do instead? We want to use a facial scrub. We want to put a barrier between our hands and the skin. So sometimes people use loofahs or scrubs. They might put ice on their face or their head. This is a great one because it's, again, giving another sensation to their skin, but keeping their hands busy. It's helping block that urge. Brushing their hair, using dandruff shampoo, because there's a nice tingling sensation that comes with that. Habit. So again, increasing your awareness, making it hard to pull. And so different strategies here that we talk about, wearing Band-Aids on your fingertips. Different things. One is it reminds you, it brings to your awareness that you're working to decrease a behavior, but it also, with fiddling, makes it harder to pull or pick, so that becomes very helpful. Wearing glasses is great because if you're pulling from your eyebrows, your eyelashes, it just provides a block, a deterrent there. Often my clients will tell me they don't like pulling when their hair feels a certain way. So for instance, if it's wet, it's just not satisfying. So they'll kind of keep it wet or put extra gel in it when they get home and make it feel kind of yucky. Over on the right side, and yucky is an official clinical term, by the way. Put petroleum jelly on the eyelids. Again, they don't like that sensation. So this would be a great home behavior where wearing a hat in some schools is allowed. Other ones it's not, so you have to be creative. Always also recommend in the beginning getting rid of your tweezers. It just becomes too much of a trigger. And so some of our suggestions we'll talk about tonight are good in the beginning, and it doesn't mean always. Environment. So instead of pulling, change your environment. My clients often say, well, I pull in my bedroom, I pull on my bed, I pick in the living room. And so we'll help you change your environment up, move the furniture, sit on a different floor, keep the door open. As parents, we won't, I often say, you want to be collaborative with your child. You don't want to tell them what to do. You want them to feel like they're in control and you're there to support them. But a suggestion, like if they're ready to keep the door open, does certainly deter the picking and pulling. I really like the reminder notes that's right above that. That is a great way to have Post-its, and I've said to clients, you could put one in the kitchen if you don't want your siblings to know what it says. Write the word moose, and you picture a moose, it's funny, or a sheep, which would be more applicable to fiddling sheep here. And no one knows what that means, but for you it's a reminder. It's breaking up your environment and saying reach your goal. And lastly, cover, remove the mirror. Again, initially, if people are staring at their skin, doing a lot of skin picking behavior, they're trying to make a pimple look better, quote unquote, but if they're picking at it, making it worse and worse. If they're not looking in the mirror, they often report a great sensation of relief, and that helps. And then finally, two more, but emotions. So instead of pulling, deal with your emotions. So many great ways to cope in a positive way. Talk about how you feel. Exercise. Meditate. Do something fun. Call a friend. Write your feelings down. Keep a journal. Go for a walk. Take a break. So many different ways. And again, what doesn't work for you, try another thing. I often say try a coping strategy a few times. If it's not right for you, try something else. It's just about finding what's right for you or for your loved ones. And then finally, perfectionistic. Be more flexible. Challenge the unrealistic standards or thoughts that they have to be a certain way. And here we have look at your progress, not just the slips. Use the strategies that do work for you. Expect that hair regrowth will come in uneven. Same with skin growing. Sometimes there's a wound there, and that's the hardest my clients report. They want to pick at it. It's that wound, it's that scab, and it's really helping them work through that step to know that, it will happen. And doing it one step at a time and being patient with that. Okay, so it's one really great strategy we use with all of the presenting problems tonight, whether it's trick or Tourette's, BFRBs, anxiety. What we do is we anthropomorphize the trick or BFRBs. What does anthropomorphize mean? Nice big word there. It means personify, create the other. So we stand up to, let's say, the BFRBs, and we become the aggressor against it. So with kids, I often have them put a name, have a picture associated with their anxiety problem or their BFRB, and draw a picture, and they stand up to the anxiety monster, the worry meanie, or whatever it is. But for teenagers, they often maybe don't give it the cutesy name, but they find that they call it the anxiety, and it's very important to personalize it and make it a third person. So I, as the therapist, can work with them, and the parents, we could all be on the same team against this monster or animal or thing or whatever it is that they decide. And even with adults and young adults, I find that they can relate to, let's say, the Mucinex commercial, where the bugs come in your mouth and you take the medicine and it clears it all up. And it's a nice picture, it's a nice metaphor of we're standing up to this thing. And so, again, we look at it, recognizing the propaganda that this monster is going to try to say, you will fail, you're too weak, what you've done doesn't count. And through actions, we're going to show it that it does. And it's very satisfying when we get to stand up to the problem in that very third-person personified way. And although it does mean we feel discomfort short-term, we get a lot of long-term relief, which is very important. I use the fearmometer with all my clients, kids and adults. And this is a 1 to 10 scale of measuring your anxiety, measuring how much your urge is to pick, pull, or whatever it is at that moment. 1 is, none at all, piece of cake, and 10 is out of control, ballistic. This is a great strategy for teachers if they're, communicating with the family or parents, just to do a quick fearmometer reading, say, what's your number? And you get a sense of where they are in the fight, so you know how much you could proceed. Different relaxation techniques I'm going to go through with you briefly now to give you an overview of what's available. So the first one is diaphragmatic breathing. The key here is to learn to control the breathing in your body. And it's not about holding your breath or doing anything different. It's just about learning to breathe from your diaphragm, which is your belly breathing, we call it, and get a deeper, extended breath. I'm going to jump down a bit to something we call practice paced breathing. That's under diaphragmatic breathing on this slide. And with that, what we'll teach you to do is a 6-second breath. So it's 3 seconds in and 3 seconds on the exhale. And that creates a very slow and steady breath where it's 1, 2, 3, relax, 2, 3. And the relax signals the exhale. I just did that quite quickly, but if I was actually doing it in session, I'd be counting on the second hand, which you'd be surprised to hear how actually slow that is. And so those are some nice, important things to control the physiological reaction of anxiety. And on top, we have something called progressive muscle relaxation. It's learning to tense and relax different muscle groups and learning how to get better control of those. And then finally on the bottom we have incorporating relaxation visualizations, and that's important because you get to take yourself to that calm place, that happy place, and helps you really let go of the fear you're feeling in the moment. Mindfulness meditation is another great relaxation technique where it's not about not thinking about a thought, but just being aware that a thought is there, learning to tolerate our thoughts. And sometimes just being aware, there's that thought again, here it is, and kind of like a luggage carousel at the airport. Baggage come and go, but that's all it is. They keep coming and going, and if you don't pick up your bag, it'll go away, and then it'll come back. So we have a distance from our thoughts, which is quite helpful. And then sensory grounding, another really nice technique for relaxation, which is different tools. The first will touch an object, sensory, and describe it and focus on it. The second minute, we'll look at an object and describe it with its size, shape, marks, colors. And the third, we'll listen to the environment around us. Again, with anxiety, it's really good to refocus, help ground us in that moment. And again, with anything I'm talking about tonight, I always recommend that you practice these techniques during calm times, because when you're anxious, it's much harder to implement. So like a firefighter running into a burning building, you want to practice how to use that hose with the water coming out of it before you go into the big blaze. So always practice all these strategies during calm times so you have it during anxious times. And finally, I'll end with this cute slide that says, be patient and non-perfectionistic with relaxation. And so the man is saying, I'm finally learning how to relax, but unfortunately it makes me tense. So nice humor there. So now I'm going to move into another area of anxiety, and this is our cognitions, or our thoughts. And what's really important, and we do this with teens, young adults, kids, older adults, this applies to all the age groups. And so what we believe in as a cognitive behavioral therapist is that an event happens. It's not the event that makes us anxious, but how we perceive the event that creates the anxiety. And so what happens with anxiety and even depression is that we tend to see things more negatively. Our goal is to help you see things more realistically. Often people expect me to say positively, but that's not so. It's to help you assess things to see it more realistically, and that helps you. It's often much more positive than the negative thinking associated with anxiety and depression. And so here we have something we call them our automatic thoughts. What an automatic thought is, it's just that thought that enters your head that says, you know, oh no, someone's judging me negatively, like in social anxiety. And often the thought comes in and out so quickly that they're just left with that terrifying fear of, I can't do this oral report now. I have to get out of here. And they have no idea what that thought is. And so what we'll do is we'll help coach people to catch that automatic thought. And once you catch the thought, we'll often notice that there's errors in that thought of I'm in danger and everyone thinks that, you know, I'm going to do terrible. And what do we call that? Cognitive distortions. And so again, the cognitive distortions are the exaggerations in our thinking. And what we'll learn how to do is identify the automatic thought and then identify the cognitive distortion, which I'll go into in some detail coming up, and then challenge those thoughts. So with kids and teens, we like to do the feeling faces. What are you feeling right now? It's a quick, easy way to catch the feeling. And with kids and teens, we might use a slide that looks like this. So again, we might start with, you know, what was I feeling? I was feeling scared and anxious and worried, and then go back to what was I thinking and what happened. And there again, the worry scale, 0 to 10, often links with the feeling and the thought. So it all kind of, as we say, makes sense. For adults, we do something called cognitive restructuring. And what often we see when we're having an overly anxious, distorted thought is we're overestimating the probability that the bad thing will happen, and we're catastrophizing the outcome of it. So not only will it be likely that I'm going to mess up my oral report, but it's going to be so catastrophic that I'll have to leave school because everyone will laugh at me every time they see me, and so on. And once we capture that overestimation and catastrophizing, we could actually explore the facts and the history and look at the evidence of what they're saying. Do we have any evidence that in all the oral reports you've ever given that you've messed up so catastrophically? And often clients can then say, well, no, it hasn't happened. Or, yes, you know, actually, I did mess up last time. And then we want to help them with the, well, what ifs, or the so what. So what you messed up? What happens when you've seen other people look anxious or their face turns red, which is a more likely event? So what? How can we decatastrophize that outcome? And we make plans to deal with the situation if, in fact, the automatic thought is true. And again, another nice form of detective thinking, which changes from what am I worried about into what is my calm thought. And you see we take our clients through the steps of what happened when I was worried before, what are the facts, what else could happen. So it helps the thinking leave negative thinking and become more realistic or calm thinking. So here's a really great form that, again, we tend to use with older teens or young adults. And this is a list of 10 different cognitive distortions. And this was originally created by David Burns for depression, but the anxiety community thought this applied so well that we borrowed it, and it really works so well. So let me give you some examples of this. First one, all or nothing thinking. Here an individual sees things in black and white categories. So if your performance isn't perfect, you've failed. There's no difference. I just had a client in earlier who meets people and they're either liars or they're not. And we were kind of playing around a little with those shades of gray. Well, what happens if someone lies and says they like your shirt and they really don't? Is that an okay lie that, you know, they're not trying to hurt your feelings, and playing with the shades of gray? Another one that's really nice on the bottom that is specifically for anxiety is jumping to conclusions. We tend to make a negative interpretation without the facts. So whether you're doing mind reading, you arbitrarily conclude that someone's reacting negatively to you and you don't check it out, or you're fortune telling. So you anticipate things will turn out badly and you feel convinced your prediction is an established fact. And so mind reading is in the moment, this person doesn't like me, or fortune teller error, I'm going to do an awful job on this presentation tonight and I'm so anxious about it because I know I'm just going to mess up this webinar terribly. And you can imagine if I'm telling myself that, how I'm feeling. And now finally, let's go through a few more. Emotional reasoning. You assume that because you feel negative emotions, then it must be true. So I feel like, you know, I feel like I'm contaminated, therefore I am, and therefore I need to keep washing and washing until I just don't feel it anymore. And often we learn that just because we feel it doesn't mean it's true. Often we say the symptoms of our disorder are misleading, and we can't trust the anxiety or depression, and we have to go against it. All right, so again, these slides will be archived, so there's some really great points. For time's sake, I'll keep going, but I encourage you to come back and read through them in more detail if this is something that really feels interesting to you. And again, some more details, detective thinking for social phobia. And so the child is saying, I will look stupid, everyone will make fun of me. And if the therapist or the parent is kind of coaching them and helping them, what will happen next? Did this ever happen before? What will it be like a week later? Will anyone really remember it? and how will it impact you. And so now exposure, that's our third strategy. So first we have relaxation, second we have cognitive therapy, and third we have exposure, which is facing the fear. And here we teach the clients to see their fears as a bully that's bossing them back. And so what do we want to do? We want to boss back. We ignore the bully, or we do the opposite of what it wants, do it differently, and that's where we're going to get our power back from some of these behaviors. There's three goals of exposure. And exposure we do with OCD. It's a really important and one of the key elements, because in OCD we're doing exposure response prevention, ritual prevention. And even in all the other social anxiety and GAD, we want to do exposure because we want to learn that you could deal with these feelings. We also want to see that feared consequences are unlikely to occur if the fear is irrational. And we also want to identify skill deficits that need to be worked on. With ERP, which is what I just mentioned, again, exposure response prevention, which is particularly applied to OCD, but again, it can be applied to different problems. Why would I do something that makes me feel bad? And the answer is because it helps. By facing our fears, we get used to them. We call that habituation. Our body gets used to it. And this is really important. So here we have a nice slide of people jumping into a frozen pool. Why would we do that? Well, here they do it because they think it's fun, and they know that after the initial shock of that cold discomfort, their body's going to get used to it, and it's going to get easier and easier. And so we say don't feed the cats. If you have a stray cat and you keep giving it milk, it's going to keep coming back. And so initially when you decide you don't want to feed the stray cat any milk anymore, make it louder, and they're going to meow more and more. And if we stick to our guns, it will go away or dissipate. And this is a great metaphor for the anxiety, for the trick, for the BFRBs, because the more we enforce it, the more we feed it, the more it's going to come. And if we can resist it or change it or do it differently, then again, we're going to be decreasing our symptoms. And with ERP specifically, we're forming hierarchy of fears. So we don't just plunge into the cold pool in therapy, metaphorically. We do it one step at a time. And so we always say start easy and work up. And I always say to clients, if you can't do that, what can you do? Which is really important. And so it just shows over time, the more exposure you do, the more you face the fear, we call it flying into the darkness, the more you're going to be free and the more you'll habituate. And so dealing with motivation is really important because I always say having anxiety and trick and BFRBs is harder than the therapy itself, but the therapy itself can be hard. And so we want to help motivate individuals. So we recommend that, family and friends will no longer make certain accommodations. So it makes it harder to deal with their symptoms. If a parent is constantly providing reassurance, then often the teen or young adult doesn't feel it's so necessary to do the therapy because they're getting that relief, even though it's short-term and feeding their disorder, they get that. Also, we'll do motivational interviewing. So we point out, how is anxiety stopping you in your life and not being able to do the things that make you feel better, and some things you'd like to do when you're less anxious are. Also empathizing, so having the confidence to get better and having those support people around you that help you and understand that this is hard and it's hard work, but you will get better and you'll get more in control of your symptoms. And if that all fails, bribery ain't so bad. And this is a nice one for kids. Although we prefer to call it reinforcement, this works for teens, young adults, and adults. We all need that. You've done a really hard effort to resist the impulse to pull a part of your hair. Go out and do that nice thing for you, whether it's a privilege, whether it's, that ice cream, whether it's just something or an event with a parent, or just something really nice that gives you a reward that can never be understated. So now, as I mentioned, we're going to talk about some of the difficulties in school, and so this is going to gear in more towards the educators or the teachers in our audience, but really also for the individuals who go to school as well as their parents. And so, as we said earlier, being surrounded by peers is very difficult for people with social phobia or any type of anxiety. Anxiety makes it hard to focus on lectures, schoolworks. Different OCD symptoms like perfectionism can cause homework tasks to take much longer. We see with one type of OCD is that a client doesn't like the way they wrote certain letters in their homework, so they'll erase it and keep rewriting it. Well, they'll be doing that so much there'll be a hole in their paper, and they can't get through the homework, not because they don't know the information, but because their symptoms are so severe. And this often leads to school refusal or different phobias. And so some strategies for dealing with anxiety in the school setting. One thing I want to mention is sometimes a parent can call a teacher and they can implement some simple strategies. Other times I really recommend going through the school psychologist or the school counselor. There's different steps in a school setting, whether it's a 504 plan, which is something made up with the school team, or an IEP, which is more of an assessment, and then they get a certain plan that is required to provide different accommodations that are necessary as a person is learning to deal with their anxiety. And so some different suggestions. One is using assistive technologies. So sometimes computers really help with that compulsive erasing I was just mentioning. And sometimes audiobooks for the student who has to count lines or letters over and over again. I believe it's important to allow extended time on test taking. Again, the goal of school is to make sure the child understands, or the teen or the young adult, the material, and we never want them penalized for having a disorder. I just had one of my OCD clients who really struggles with this but has come a long way, applied for extra time on her SATs because she's quite bright, but often will wind up, if she just had the allotted time, with not even half of the exam done, and she would be quite penalized in her score if that just reflected the time. And also allowing students to have different assignments. So maybe if presenting in front of the class is too difficult, again, we want to work one step at a time. Maybe they start with presenting to a teacher before school, and so they don't have the audience. Other creative methods for tracking their assignments, whether they have a teacher assignment book, they might email assignments home, leave voicemails, providing an assignment or activity plan. So you could see this is really a collaborative effort between the school, the home, the teen, the young adult. In college, things are different. You know, again, certainly in colleges, there's wonderful support services, disability support services that I encourage clients to utilize because they're there for these accommodations. And the message always is that use the accommodations, but as you get stronger in your therapy skills, you may not need them anymore, and then we don't use them anymore. Breaking down large assignments into more manageable tasks. And again, the idea here is quality, mastering the material, not quantity. So sometimes just having less homework is helpful for a student. Different seating is helpful. If a student really thrives in the front of the room, there might be just too much distraction in the back, or they might be less likely to do some of their BFRBs if they're in the front of the room, so that's going to support their goals. Also allowing them to leave a room if they're having an anxious moment, and maybe setting up a signal with a teacher that they don't have to wait for the other student to get back with the hall pass, and different things like that. Also, going home or staying home should be the last option. We really want a guidance office. Home, we often recommend setting it up so it's a no-fun environment. So there's no TV or computers or cell phone while the school day is going on, and they're really engaging in some kind of learning activity or working on their therapy during that time. As we talked about earlier, always involve the student. They're the main person involved here. I like to say they're driving the car, and all of the parents and professionals surrounding them are sort of holding nowadays the GPS next to them. So we're the experts. We know where we want them to go, but they have to be ready to go there, and they're hitting the gas and going faster or slower at different times. We're also educating students and teachers and support staff, because compassion really goes a long way. Sometimes teachers are frustrated not understanding why a child is having a tic, and giving them the understanding that this is a neurobiological disorder helps them understand it and helps them understand how they could support the student without any kind of penalization. And finally, in conclusion, in dealing with anxiety, we work to help the client challenge irrational thoughts or problem solve if the source of their anxiety is a realistic fear. The hope is that clients learn to manage their fears so they can take this and make it look more like this. All right? So that's certainly our goal. And for further information, I've listed a few different organizations. We have the International Obsessive Compulsive Foundation, ocfoundation.org. We have some different behavioral and cognitive websites, and the one that's not listed, and that's because this was a previous slide presented at a national conference for trichotillomania, so they were already at the conference, but one is www.trich.org, and that's for the Trichotillomania Learning Center, and that covers Trich and BFRBs. And of course, you're all here tonight, so you know about our New Jersey Center for Tourette Syndrome, which is a wonderful organization and a terrific resource that we're lucky to have tonight. So at this time, I will conclude the presentation, and now I guess we'll turn it over for some questions.
Well, I almost don't know where to start. Thank you, by the way. That was a really excellent and informative presentation, and we have quite a few questions, so I'm going to start right away.
Great.
So, have a question having to do with an 11-year-old child. Could it be obvious to a child this age that they are experiencing stress, and how can a parent help a child recognize their stress? So, is it really obvious to them, and if it's not, how do you manage that with a child that age?
Good question. I think absolutely. Young kids as young as 2, 3 can verbalize some worry or fear. I'm worried that mommy and daddy are leaving. I'm worried about separation. And so they may not have the vocabulary for it. So that 11-year-old certainly knows what they feel. And I think it's really important as a parent to give them the vocabulary to normalize it to some degree and to say this is anxiety and worry, and you know, this is okay what you're feeling. You have a big test coming tomorrow. And when you see it getting out of hand, to say that, well, I really think your anxiety monster is messing with you and trying to trick you and think that, you know, you can't do this, but of course we know you can. And so I certainly think that at all ages we want to give them the language to understand anxiety and worry.
Okay, so does that, so how does, beyond then the parent giving them the language, where else then would you say that the parent could make a difference?
So again, I go back to all the different coping skills that we talked about today. So on one extreme, if your child, the 11-year-old, let's say, is really suffering with anxiety and worry, then we always say take them to a professional. If one of the points I want to convey tonight, and I'm glad I have an opportunity to do so now, is that for the parents, for the school personnel, your job isn't to treat these disorders. I did give you a lot of treatment intervention strategies tonight, but the job is to make the referral. The educator is say to a parent, you know, I'm seeing your child really upset in class, and why don't we get an assessment done? So whether that's a clinician, a psychologist, go to a professional that is trained to treat anxiety disorders. And so that's a good start. Now, on the other hand, let's say that your child is just having normal worries and you feel like you can manage that. Then we go back to the slides we did tonight. All of this applies. So you want to help them with relaxation. You want to teach them some breathing exercises to calm their body down. You want to help them do detective thinking, which is great for 11-year-olds. Help them catch those worried thoughts and change them to calm thoughts. And then you want to help them face their fears. A lot of 11-year-olds get really worried about sleepovers, sleeping out of the house. And so you help them pick a best friend that they could start just having a late night with, and you pick them up. And then you build on that one step at a time in terms of facing your fears.
Okay, thank you. Great answer. Have a question about hair pulling having to do with, I'm not quite sure an age here. So the question is, the daughter knows she pulls, but she claims she doesn't know when and where. The mom says that she thinks she's doing it at school, but the fact is that she keeps, she always says she doesn't know. I guess that's the bottom line. She just does it unconsciously. Is that possible?
That is, yeah. So we find that it's mixed with hair pulling, and similar to tics, there's some different levels of awareness. So sometimes people report with trick that I'm fully aware of my pulling, I know I'm doing it, and I wish I wasn't, but I am. Other times, the child or teen or young adult will say, I just, all of a sudden I look down and there's a clump of hair on the floor and I had no idea I was doing it. And so what we want to do, whether in therapy or with the parent, is increase awareness. Now the first step, of course, is increasing motivation. So that child has to want to stop pulling. If they don't, then it's my job as a therapist to build in the motivation. Well, what are the consequences of your hair pulling, and how is that upsetting you? And so that's where we would start. So assuming they have the motivation, they want to increase their awareness, then you come up with all different strategies. If you go back to the slide for fit and sheep revolving habit, that's all about increasing awareness. Do different things like putting Band-Aids on your fingers. In that case, you're not doing it to make the hair pulling harder. You're doing it so when they see their finger, they go, oh, right, I'm trying to prevent that pulling behavior. Now, of course, if they're right-handed and they're pulling with that, put the Band-Aid on the right hand so it makes it harder to pull. Can't hurt to do that. But you want to do all different behaviors. If the child is amenable to this, we always recommend, and this is with, we use this with tics all the time too, is coming up with a signal, whether the parent just sort of lifts their finger in the air, you know, and does a certain signal to the child, hey, this is what you're doing. So it's really subtle, and maybe the people in the house, like siblings, won't pick up on it, but it helps increase their awareness. Again, with all of this, you want to be collaborative and get their feedback on that. But there's so many different strategies to increase awareness, and once we have the awareness increased, then we could do different interventions.
Okay. I have a couple of questions about nail biting. So they're similar questions. One of them is, do kids ever outgrow it? And the other one has to do with, how do you stop a lifelong nail biting habit in an adult?
So yes. So the first question is can someone stop? Absolutely. Now again, it doesn't mean that it will go away forever and never be an urge, but I've had clients who come in with that specific presenting problem and they learn to manage it. Now sure, at times of stress or different things, that urge can be there, but some of my clients have been so masterful in terms of their awareness that they really are so motivated to get that in control that they've really come a long way. So there's different ways specifically with the nail biting. Again, we talked about the manicures. That goes such a distance for clients because they really can see that if I have this pain on my nails, I don't want to ruin it, and it really helps build success. And there's different things like wearing gloves in the house, so your fingers are covered, and that just lets the urge get stronger, but when you don't do the behavior, like the biting, you realize that the urge will pass. This is really important with any of the things we talked about tonight. Like a wave, an urge to have anxiety or pick or pull will get strong, but then it will dissipate. And it's really important to be able to ride out that wave for a child or an adult. And I believe that certainly you can intervene at any age. So if it's been a lifelong struggle, using these different fiddling and different strategies to increase your awareness. You know, I have clients in the beginning of our treatment, every time they put their finger in their mouth, they have to take a piece of paper and a pen and tally it. And imagine how annoying that is.
Oh my gosh, yeah.
Yeah, so part of that, we want to pair up a pleasurable. Remember, we talked about BFRBs can be pleasurable. It's a source of relief. We want to pair that with a negative behavior. And so by having that tally need, it's annoying, you know, so I won't make them do it all the time. We'll kind of contract for, hey, you know, after school for a few hours, have that pen by you, and every time that finger goes near the mouth, you have to put a tally mark down. And it really deters them from, oh, I just don't want to put that tally mark down. I'm not putting my hands in my mouth. And it does go a long way that, again, over time they stop the tallying because their awareness is so great at that point.
It's also it's also kind of crazy when you're counting each time you do it, and those numbers get up there. So
yeah, it really does lead to awareness.
Yeah, I have another question about hair pulling, and I just need to pull it up here on the screen because it disappeared on me. It has to do with, how do I stop hair pulling if part of my brain doesn't want to stop because it feels good? So can you talk about that a little bit?
Sure, it's a great question. Again, what you'll notice from a lot of the strategy lists we talked about is we're not just saying don't do anything so you're sitting there feeling miserable. We want you to replace it with other things that feel pleasurable. Now, in truth, I do have clients who say, okay, you know, taking this hairbrush that's horse bristles and rubbing it through my head, you know, feels nice. It feels tingling on my scalp and I enjoy it, but I'd rather be pulling. We get that. But at this point, again, the consequences for their trick is so severe that they're really motivated to make a difference. And motivation waxes and wanes, so that's okay. And in willpower as well, but what you want to do is just keep the behaviors constant, so you have in every room you go to, you have, we call it like your trick strategies, your fiddle strategies. So you have under the couch, you have that, you know, your koosh ball, your silly putty, you have your worry bracelet, whatever it is for you, that's going to be that strategy that works. You have it everywhere. And in your car, and you have it at your desk at work or at school or wherever you are. And so it's really going to help increase that awareness. And what you're trying to do ultimately is do something that feels pleasurable as well. Again, it may not feel as good as that releasing endorphins of the pulling, but it will feel good. And over time, when you start, I have a client who came in who had no eyebrows when I first started working with her, and how good she feels now. This is a teenager who was in my office just yesterday, and she feels so good that her eyebrows have grown back in, that she still uses the Vaseline on her eyebrows at home and things like that, but she's so motivated to sort of not give the trick monster what it wants, and to have this relief that she could go to school and not have people ask her, where are your eyebrows and what's going on, and that for her it's so motivating that it outweighs the pleasure of the pulling, if that makes sense.
So in that case, in that example, then, that individual has learned to manage their pulling. So cure is not quite the answer, but manage it successfully with a variety of strategies would be the more appropriate answer, I guess.
I would certainly agree. You will get those small subset of clients who say, I just don't feel the urges anymore, I feel cured. But in our language, I like to look at it more as managed. I think with a lot of the anxiety disorders like OCD, with Tourette's, with trick, with BFRBs, it's about managing. So you're recognizing that you may always, in those times of different emotions, have that urge, but what we say is the urge is much less. It's not as strong as it was, and it could be bypassed because you're not reinforcing it anymore. And so that's really important. There are some different anxieties like panic disorder, which we might more confidently say we can cure that. We can really help you get rid of your panic, even though anxiety may last, but panic can be cured. So I think that would be specific to each disorder.
Okay. Here's one posted that would probably interest a lot of parents out there. Can parents, and this is in quotes, can parents cause their child to have anxiety disorders? Or for that matter, how about traumatic events? Can something like that cause an anxiety disorder?
So the good news is parents, as a parent myself, we're off the hook. We cannot cause an anxiety disorder. There's multiple factors that lead to the presentation of an anxiety disorder. So I guess in the truest of sense, our genetics do contribute. We do find that there's a family link with your mom has, let's say, or dad has anxiety, then there's a chance that your offspring will have an anxiety disorder, not the same one or maybe different, but there's more of a family contribution, so that is present. However, there's definitely environmental factors that contribute to that genetic predisposition that will add to that. And so a traumatic event, if the person was not, let's say, predisposed to it, they're not going to develop an anxiety disorder because of a traumatic event. If we look at something as severe as 9/11, some people developed what we call post-traumatic stress disorder, and others didn't. And we kind of, researchers scratch their head and we say, well, why are people, quote-unquote, more resilient? How did some people manage with just obvious anxiety but not develop into a disorder? And that just becomes the unknown, the mix between genetics and environment and the contributing factors. So we always say that stress doesn't cause these. So stress will not cause OCD, it will not cause hair pulling, but it certainly can exacerbate it. And I like to make that, I think that's an important distinction between those two.
But it's an integral part.
Yeah, certainly. And it links with it, but it's not causal. So it'll make it worse,
okay,
but it won't cause it.
Okay. I think we have time for one more, and I think maybe this is kind of a little lengthy, so I'll abbreviate it, but I think it kind of says a lot about this topic.
Okay.
So we have a daughter, I don't know how old. Oh, here it is, I'm sorry, she's 11. And
okay.
The daughter says she doesn't worry about anything. She seems happy, she's a pretty, balanced kid. However, she has ADHD and is a picker and a nail biter. So the parents have done the things that you've described, Band-Aid on the finger, chewing gum, and other strategies. But their concern is, right now it's not interfering with her world, yet they worry about if it will continue to worsen. So could you talk a little bit about a pretty well-adjusted child, it sounds like, who yet seems to have some stuff going on?
Sure. Yeah. Again, often if, the child is not concerned about it, and they're not having those kind of consequences, they're going to be much less motivated to gain control or have any intervention for that. So it might be the kind of thing where they're not. So one other thing to emphasize is there's not, again, a causal link between anxiety and hair pulling. Some people pull their hair because it feels good, because they're happy. And so I'm always happy to clarify that misconception that people who pull their hair, have BFRBs, are really nervous people. It's not so. You know, there's certainly times where we report that, and again, as I said earlier, stress could make the behaviors worse, but they're not connected in the sense that, you know, someone's really happy or they're tired. A lot of my clients are tired and they tend to pick more. So it's not connected to anxiety. So that, just to confirm, can certainly be possible with that child, that they're not having anxiety connected to the behaviors. And then the second part of that would be, understandably, parents are concerned about those negative consequences I talked about earlier, and that makes sense. They could certainly talk about that with the client and come up with, well, do you think that you ever worry about, you know, your classmates noticing that bald spot on your head? Or, you know, sometimes if we feed the trick monster, it could get bigger. But if the client feels like, you know what, this is a small part of my life and I'm pulling from maybe body hair that's not evident to their peers, they're much less motivated, and it becomes something that isn't talked about. It doesn't need to be something that the parents, let's say, worry about now. If it's not, again, creating functional impairment or creating distress, then often, you know, there's not a problem there as we see it. It just becomes a behavior that's a bad habit, let's say, or just something that, you know, the parents don't like as much. But if the child isn't negatively impacted by it at this time, then it's something that's discussed, observed, because you don't want the pink elephant in the room, but it sort of is what it is. Does that answer that question?
I think so. If it's not making, if it's not harming in any way,
Yeah.
then sometimes you just have to let it go. It's kind of like that nail biting a little bit.
Right.
You know, it doesn't look great, but if everything else is functioning, then maybe it's one of those things that you just have to, you know, just have to live with.
Exactly, and sometimes it's much worse for the parent because of the future concerns, because of perhaps what it looks like or their fears they have for their child going out into the world, where the child, teen, young adult doesn't care at all about it, and it's no big deal. And so it becomes one of those things that if the individual is not worried about it, then we don't encourage an intervention, or, you know, because it'll never happen. If the individual isn't motivated to make a change, then it'll be an uphill battle.
Mm-hmm. All right, well, I think we need to end it here. For those people that posted questions that didn't get answered, we'll certainly make sure they get on the blog, and
Sure.
And they'll be covered there. Doctor, thank you very much. That was a really informative presentation. I really appreciate your nice job tonight.
Well, thanks so much. It's my pleasure speaking to everyone tonight, and thank you for taking the time to listen.
Thank you for joining our webinar on body-focused repetitive behaviors. There is an exit survey which we need everyone attending to fill out. The discussion board blog is now open and available for the next 7 days on the NJCTS website for any additional questions that we didn't cover in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the website by the end of business Friday. Our next presentation, Using Creative Arts Therapy, Benefits of Music, Dance, Movement, and Art Therapy, will be presented by Kathleen Nace and is scheduled for March 26, 2014. This ends tonight's webinar. Thank you, Dr. Strohl, for your presentation, and thank you, everyone, for attending.